Welcome to another educational video about disorders of the spine. I'm Dr. Ezriel Kornel, a neurosurgeon practicing in the New York area. I'm a brain and spine surgeon, and I'm a partner in Brain and Spine Surgeons of New York in White Plains, New York. I operate at several hospitals in both Westchester County and in Manhattan, and I'm an assistant clinical professor of neurosurgery at Weill Cornell Medical Center. Today we're going to be talking about disorders of the cervical spine, in other words, of the neck. And here to help me to understand these problems is my very close friend, Susan Keith. Susan, thanks for coming again to talk about problems of the cervical spine. You know, I have patients coming in to my office daily who have problems of the cervical spine, and they don't really have a good understanding of what's going on, even though they've often looked up these problems on the internet, talk to friends about it, talk to other doctors about it. And so I like to educate them about their problem before I tell them what I think they need to do about it.
That's great, because then they'll come here and they'll know, they'll be better prepared.
That's the idea. And so you're going to help me because you're going to ask me questions as I try to explain to you.
Oh, good, because there's plenty I don't know about this. Fortunately, I guess.
Well, hopefully I can get you some valuable information and you'll be able to now be an expert on problems of the cervical spine.
Holy cow, already? That's fast?
So there's an important distinction between the spine in the neck and the spine in the lower back. And that distinction is that the spinal cord runs through the cervical spine down to the top of the lumbar spine, but not into the lumbar spine.
So you mean the vertebrae isn't just one long vertebrae like we always think of it?
No, I'm talking about the spinal cord.
Oh, the spinal cord.
And the spinal cord is critical because that's the structure that if it's injured, you become completely paralyzed. If it's injured in the neck, you can lose function in your arms and your legs. If it's injured in the lower part of the neck or in the thoracic or mid-spine, then you're left with weakness in your legs. You can also be left with problems with the muscles of the chest and breathing problems and problems in the abdomen because all the nerves run through the spinal cord.
Is that what happened to Superman, Chris Reeves?
Yes, he had a fracture in the upper part of the cervical spine which left him not just with problems of loss of function in the arms and legs, but also with problems breathing. So when Christopher Reeves had his injury, he had a fracture in the upper part of the cervical spine which affected not only his arms and legs and paralyzed his arms and legs, but also caused damage to the areas that control respiration, so he couldn't breathe on his own. It also can affect the nerves that go to the heart, so your sympathetic system can't respond properly, so your heart rate can alter. And so there are a number of physiologic problems related to the spinal cord, because the spinal cord is the tract, it's all the nerves that go from the brain down to control the muscles, and all the information that comes from your entire body that goes to the brain so the brain can act on that information.
So it's kind of like your FiOS or your cable that goes in?
It is the major cable, and when that's disrupted, there are no accessory channels to follow. There's no other system by which nerve information can get to other parts of the body. So the spinal cord is critical.
So Eddie, when Chris Reeves he was determined to get himself better. Did they do everything possible or was it really hopeless to begin with?
Well, the research that's going on is to try to get repair of damaged fibers in the spinal cord. And what happens when there's disruption, there is a part of the spinal cord that actually dies. So you need to put in new nerves that can grow to connect. And the challenge is to get nerves that connect to the right nerves. You can't just connect in a tangle. Right. You have to have nerve connecting the right nerve, so that the nerve that goes to your brain that tells you that you want to move your right foot has to be hooked up. And so the research is going into discovering ways in which these nerves can reattach. And it may be that we can find a way to do that that's remarkable it's different than what we've known about in the past.
Is stem cells one of the ways that could work?
Stem cells could be one of the ways. But we're getting
off on something else.
We're getting to a very interesting topic, but it's in a much more complex and experimental realm.
Okay, so someone gets whiplash, and and they have to be put in traction.
Well, usually you don't have to be put in traction with whiplash. So let's start out by focusing on the kinds of things that surgically can be rectified.
Okay.
Because usually whiplash is not something that's going to require surgery.
Oh, good.
So let's start out by defining the anatomy of the cervical spine.
Okay, great.
So you have the vertebral bodies, which we've talked about in the lower back. Same thing in the neck, but the vertebral bodies are, of course, much smaller. And the forces on them are less. So the discs, which are the cushions in between, are smaller. And they have to deal with less stresses. But still, you've got a head that weighs a good amount on top of there. So the neck does have to support this bowling ball sort of on the top. Mm-hmm. In the back, you've got, again, the bones you can feel when you run your hand up and down your neck, the spinous processes, to which all the muscles attach and then allow for movement of the spine. And you've got the paired joints on either side. But the important thing is you've got the spinal canal in the center, and the spinal cord runs through there.
Right.
So the disc, again, a healthy disc has a lot of elasticity to it, and it's well hydrated, meaning there's a lot of water content. When you compress it, it re-expands. It's a living thing, but as it gets damaged, it loses its water content. It becomes drier. It doesn't have the resiliency anymore. And as it collapses, the bones can start to come together, and they can rub together, and an inflammatory process, and from the rubbing, you can get spurs forming on the edges of the bone. And when the spurs grow backwards, they can compress the nerves that are coming out of the spine, but they can also compress the spinal cord that's running through there. You can also get compression of the nerves if a piece of the disc actually breaks out and pushes on the nerve. It can also break out and press on the spinal cord. When you have compression of the spinal cord, you have different symptoms than when you have compression of the nerve. When you have the compression of the nerve, it's like sciatica. You get what's called a radiculopathy, which is irritation of that nerve, and that follows a particular course down the arm. If the C5 nerve root is compressed, you tend to get pain to the shoulder and the upper arm and weakness as you lift your arm.
Right.
When it goes to the C6 nerve, you tend to get weakness of the biceps, and you get pain radiating down the arm into the hand, often the thumb. And when you get the C7 nerve compressed, you get weakness into the triceps, into extensors of the fingers. So you are weaker doing extension of the elbow and elevation of the fingers. So those are sort of signatures of those particular nerves. They can also result in numbness in different parts of the arm and the hand. And you can lose reflexes. So you wouldn't be examining your own reflexes, but if you came in and you complained of a symptom, I would examine you and I'd find maybe that the reflex was changed, which would give me a sense of where the problem is. So you would come in with a pain in your neck, and it may go down the arm as well. One of the things I would want to know, aside from how much pain you're having, how long it's been going on, and how much disability you've experienced from it, I would want to know if you had any weakness in the other arm, or if you had any weakness in the legs, or stiffness in the legs, if your legs felt heavy, if you felt you couldn't go up or down stairs as fast, if you had bladder problems. Because if you have compression of the spinal cord, then it can affect your legs. Some people, of course, know already that they've got a problem with their legs. They come in and say, I can't walk as well. Just a few days ago, I had a patient who came in, he couldn't walk as well. He thought it was due to a problem in his lower back, because he had a lot of degenerative disease in his lower back. And his doctor said, oh, it must be coming from your lower back. But after examining him, I realized that it had to be coming from his neck. And the surgery he needed was to relieve pressure on the spinal cord and the neck, because there was a tremendous amount of pressure on the spinal cord.
So that was making his back hurt.
His back wasn't even hurting that much. The biggest problem was his walking.
Wow.
He was getting weak in his leg. So you can't necessarily go by pain or no pain. Sometimes people have spinal cord compression in the neck and don't have pain. Sometimes people come in with a lot of neck pain and not much symptoms that they recognize in the arms, but when I examine them, I can tell that they're having problems with their legs, and they get weakness in their hand. People get weakness in their hands. They can go on for a while, so gradual that they don't even really recognize fully how much weakness has developed.
Mm-hmm.
So it's important when someone comes in with a problem with their neck for me to evaluate whether there's evidence for compression of the spinal cord or compression of the nerves or no compression, and whether the pain is just coming from degenerative changes in the joints or the discs.
So show me what you would do for the spinal cord if it was a spinal cord, and what you would do if it was the nerve.
Well, either way you want to relieve pressure on the nerve. So the most common way that we do it is by actually going to the front of the spine, removing the entire disc, going back to the back of the disc, looking through there with a microscope, and removing that portion that's pressing on the nerve inside here or on the spinal cord itself.
And then you're able to put it right back in? What's left of it?
Well, we don't put the disc back in. The disc is shot. It's no good. We can't make it functional again. We either put an artificial disc, we put artificial disc in, which we discuss on another program, or we fuse it. The other way to approach it is through the back of the neck. We can decompress the spinal cord by doing what's called a laminectomy, opening up the spinal canal, and that can free up the spinal cord, and we can make openings over the nerve. We can make a window here and relieve the pressure on the nerve as well. This is not an uncommon procedure. I personally prefer to go where the pathology or problem is. So if the problem is coming from the front, I like to go from the front. If the problem seems to be coming more from behind, I prefer to go from behind.
How do you know sometimes which disc it's going to be that you're going to operate on? I mean,
well,
if it's not
actually, it's a better question than you realize even, because often people do have multiple disc problems. They don't just have one disc that's bulging or herniated. In fact, they may have several. So I need to, as an expert, be able to evaluate you, figure out which one is giving you the symptoms, and then tell you what I think the best surgical approach would be if, in fact, surgery is indicated. Sometimes it's just removing one disc. Sometimes it's just removing the portion of the disc that's pushing right on the nerve. Sometimes it is removing multiple discs.
And you don't know until you open it up?
No. I have to know well before that. I know it by examining you.
Good.
And I know it by looking at your MRI. And sometimes we get a CAT scan as well. But it's a combination. It's why you need a board-certified spine surgeon if you're going to have surgery on the spine, because you need someone who really understands what's going on. And neurosurgeons, of course, have been specifically trained only in treatment of nervous system disorders. We're not primarily treated to fix bones, we're primarily treated to fix disorders of the nervous system. So we have to take all our knowledge and experience and judgment to make a determination if you need surgery, what kind of surgery you need, and then explain it to you so you can understand it, so you can participate in making a decision about what's the best approach for you. And hopefully then, not only will you not have further damage, but you'll be able to recover. And the important thing about treating the spinal cord, which becomes an emergency, it's not something you can sit around and wait with. If you're starting to get weak in your legs, you're not going to wait around to see if they get stronger if you've got spinal cord compression. It's just going to get worse, and you have the potential to have a problem that becomes irreversible.
Wow.
So you need, if there are questions about whether you've got neurologic dysfunction related to compression in the neck, you need to get an expert opinion about what's going on. I actually personally recommend that you see a board-certified neurosurgeon if there's a real concern.
But Ed, if you, like say my mom, 82 years old, and her neck is hurting, but could it be degenerating so much that it's not even operable anymore?
Well, in older patients, there's certainly going to be a considerable amount of degenerative change.
So that's what we all have to look forward to.
Well, to greater and lesser degrees. Not everybody has degenerative changes that cause symptoms. You can have degenerative changes without having pain, without having limitation, without having nerve compression. If you do have symptoms related to it, then there are many other potential treatments before surgery. Surgery is only a last resort in those cases. If you don't have neurologic dysfunction, then you've got a lot of other ways to manage this before you consider surgery. And we'll go over these. Is
that why, she's getting like a hump in her back? Is it something like this?
Well, a hump is from degenerative changes.
Yeah, not really a hump, just sort of over.
Right, that's very common, and that's why it's very important to continue to exercise and maintain good muscle strength to try to keep that alignment. But we'll talk about the non-surgical approaches
good.
on another instructional video.
All right, so, I guess we're done for now. I think he's giving me the...
Susan,
that's enough for that one.
Thanks for being the
I
one
love
to
this little one.
Interesting, isn't it?
Yeah, it's very interesting. It's not as hard to understand as I thought it would be.
See?
But you're the professor.
Well, thank you. Well, thank you all for joining us on this instructional video about disorders of the cervical spine. Join us for another one of our instructional videos. I'm Dr. Ezriel Kornel. Have a good day.